Welcome back to the program. If you're just joining us, this is Bottomline Africa, right here on KTN News, where we are making sure you don't miss anything as far as all the developing stories in the continent is concerned. At this hour, IEBC, that is the Kenya's electoral body, is appearing before a joint parliamentary committee on election law changes. I understand that submission by some of the IEBC officials is still on, and at the same time, Liberia, remember, is also preparing for its own election in about 4 days, I believe. But for now, it is Thursday, and it's about time we look at our Throwback Thursday. It's all about Nelson Mandela, the late Nelson Mandela, well known as Madiba, and had something to talk about demonstrations. Let's listen in.
I feel that it is useless and futile for us to continue talking peace and non-violence against a government whose reply is only savage attacks.
Apartheid is still in place. The police are still killing our people, as they've done over the years. Vigilante groups are openly arming themselves for the specific purpose of attacking progressive groups and progressive leaders. The right wing is also arming itself openly, and they say they are doing so for the purpose of destroying the ANC.
The white minority is an enemy. We must never talk to them. But our brain said, if you don't talk to this man, your country will go up in flames. And for many years to come, this country will be engulfed in rivers of blood.
One of the mistakes which some political analysts make is to think that their enemies should be our enemies.
Take your guns, your knives, and your pangas and throw them into the sea.
Tonight, we can stand before you free. But let us remind ourselves that our work is far from complete. Where there is poverty and sickness, including AIDS, where human beings are being oppressed, there is more work to be done. Our work is for freedom for all.
Freedom icon, the late Nelson Mandela, well known as Madiba, making a case for protest, and I'm sure he was advocating for a peaceful protest there. And of course, he forms our TBT tonight, that is Throwback Thursday. Remember, this is Bottomline Africa, and let's go straight to our discussion tonight, and I have our guest ready. Good evening, ladies and gentlemen, and welcome to the show.
Good evening.
So let me start by introducing once again Dr. here, who is on my far right. He is Dr. Justus Ngatia. Yes. He's an obstetrician and a gynecologist. Yes. And then we have Françoise Mukuku. She is from DRC. She is a sexual health right advocate. Welcome to the show. Excellent. And then we have Lillian Mushoki, who is a women's rights advocate. And last but not the least, we have Mr. Albert Obayo, who is an executive director, Center for the Study of Adolescents. Welcome to the show once again. Let me just start with Daktari here. And if you look at the statistics, we were to run some video shortly, but we didn't have time, unfortunately. Statistics indicate that about 396 deaths are reported every year on, women who are, trying to give birth in Africa. That's a very disturbing statistics, I must say. Why do you think that is the case?
Well, we have many factors playing into this. Mm-hmm. And if you look at, for example, the latest Kenya Demographic and Health Survey, mm-hmm. 362 out of 100,000 live births, those women die due to the pregnancy-related issues. Mm-hmm. Compare that with a country like the UK, where we have only 9 deaths per 100,000. Mm-hmm. So you find, for us, we are far, far, far behind. Mm-hmm. And the reasons for that is there are multiple, right from attending clinic all the way to the issue of the delivery and postnatal care. So there are multiple factors that come into play, and of course cause this high mortality.
So why do you think that is the case? Is there issues to do with accessing hospitals, or basically, is it because of the teenage issues?
Of course, accessibility to facilities that offer the basic antenatal care is an issue, and also convincing our people that they need to attend clinics. And after they have done that, then the next thing is delivery at the competent and safe health care providers. You find currently we have only about 60% who are delivering in other skilled personnel. The rest, they are delivering other unskilled hands.
Exactly, and this is where I want to bring Albert into the discussion. And Albert, if you look at these statistics, a huge number apparently are teenagers. These are teenage moms who lose their lives while delivering. I'm sure most of them it's their first birth. So why do you think that is the case?
I think the starting point is that adolescent girls are starting to have sex early, and there could be different reasons for that. One of them is that we are not providing adequate sexuality education to children, and also healthcare services are not responsive to the needs of adolescents in this country. And then thirdly, the physique, the body of the adolescent girl is not fully developed to be able to carry a pregnancy to term. And therefore, if you look at a combination of all these factors, including the fact that our societal systems are also not responding to the needs of adolescents in terms of information, in terms of support, and in terms of even healthcare services, then if you combine all these factors, you can see that adolescents contribute almost 3/4 of the maternal deaths that Dr. refers to.
Lillian, do you agree with Albert that these teenagers are exposed to sex at a very early, tender age? And there are those who criticize, issues to do with sex education. They say as much as it's important, it comes in very late in their lives.
I think that has been a concern, and especially in the women's rights movement. First of all, about the debut of sex, it depends on the context. And it has been observed that in the urban setup, it starts quite early, especially in the informal settlement. And it also has an association with the economic status. So the more vulnerable you are economically, the more likely you are to have an early sex debut. And unfortunately, because of the African context, the culture, and also the religious influences, we've had a bit of a problem starting sex education early enough. In primary school, we assume that our children are not having sex in primary school, they're children. In secondary school, when a lot of teenagers are having their sex debut from the age of, say, 12 to maybe 15, we also want now to bring in the abstinence message. And by then, they're ready to already exposed to a lot of information, either from peers, from social media, because that is a channel that is really growing. And if you're not giving them the information that they need, they'll definitely go and look for it. So by the time they get to the maybe tertiary institution, or maybe they got there, if they don't manage to go to the tertiary institutions, it's already too late. And I feel like the concern has been that the kind of information that is being given is too much. It's exposing them too much and might lead to deviant sex behaviors. But I think that we've not had clear statistics on that.
Yeah, we'll talk about that shortly, about what time is the right time for these teenagers to be given this sex education. Let's talk about reproductive health, and I'm sure you've been operating on the ground. So there's some, of course, we're in Africa, and it's there's a lot of culture and a lot of tradition that is in place. So there's also even considered taboo counting your own children. So how do you make sure that when it comes to reproductive health, it doesn't clash with these traditions and cultures?
I mean, you can never say that it cannot completely clash, because some of the traditional practices are actually retrogressive. So it means that you have to break that barrier, the cultural barrier, for you to be able to empower this young girl or young woman to access sexual reproductive rights and even the associated products. So at the end of the day, the bottom line is, how do you build synergies between the culture and the rights of this teenage girl? And that has been a controversial issue. And I think that is where the rubber meets the road, because it determines whether you're going to give information. It determines access to maybe the contraceptives, access to all kinds of health care, adequate maternal health care. So at the end of the day, we need to have conversations on whether the cultures that we have are having a bigger influence on the kind of services we're providing to the adolescent girls and even the women, because the maternal mortality does not just affect the adolescent, it's affecting us in general. And it does not matter whether you're a small girl who is expectant or a 50-year-old woman, the issues are the same. So how do we start, harmonizing the cultures with the rights?
Now, Francois One, I hope I got it right.
Yes.
Actually, let me choose to call you Miss Mukuku. That's your second name. She's from DRC. And we talk about culture, clashing with these sorts of, reproductive health when it comes to reproductive health. How is the situation like in DRC?
Well, DRC is just one of the African countries, so our situation is not very different. But I would like to go back to the mortal maternity. In Congo is 700.
Yes.
Yeah, so
that's a big number.
That's
700
like twice
in
every 100,000. Yeah. So this is twice the rate of Kenya.
That's shocking.
Yeah, it's really shocking, and it should be. And I would like to say that unsafe abortion contribute to that number to almost a quarter of it. So it's really something that we should also take into account when we are talking about these rates.
And let me bring the doctor in once again. And there are those who believe, or men who believe, that this is just a woman issue. Reproductive health is just women's issues and they don't have to do anything with it. So what do you have to say about that?
Well, I think that's where we go entirely wrong, because it takes two to tango. You have to have men on board, because without them, we are not talking of pregnancies. So why should they all add with just the donation of the sperm? It should actually start there, so that we have the two together. We involve, if we can involve men more in this, I think we can do more business than just leaving it as a woman issue. Just like in the issue of contraceptives, you find, I think women have generally grabbed it as their own. Contraceptives should be a word of both men and women.
Yes.
Like,
and speaking about contraceptives for men, Dr. Adi, of course you'll have enough time to explain yourself. But those who say that these contraceptives have some sort of side effects when it comes to women. So who chooses which kind of contraceptive is meant for any woman who comes for assistance from you, let's say?
Generally, of course, there are variety, and the choice is the couple's or the woman's choice based on information given by the healthcare provider. So it is upon the healthcare provider, be it the nurse, the clinic officer, or the doctor, to give information concerning the particular family planning methods, so that the information on the mechanism of action, information on the side effects, and the effectiveness of the method, and then it's based on this that the woman should make a choice on which one to use, but of course guided by the medical
practitioner.
Yes.
Now, Ms. Mukuku, you've already indicated that the mortality rate in DRC stands at 700 in every 100,000. That's double like what we have right now in Kenya. So is this mainly contributed by the issues with, that is happening politically in DRC? Is it related to REP? And what are the authorities doing about it?
Well, It is related to conflicts, but the DRC is also a big country with very few facilities, with medical care that is one of the most expensive in Africa, with a law that is not conducive for family planning or safe abortion. So all this put together can explain the high rates. Yeah.
And speaking about family planning, Lilian, I'll come to you shortly, and I'd like to hear Albert's opinion on this. Those who say the reason as to why teenagers compose, make a huge number of these women who die while giving birth, it's because these teenagers cannot access family planning. Is that the case? Because they're considered too young?
I think in our context, the policies are very clear in terms of who and who should not access family planning services. I think the law says that those who are sexually active, whether they are having school uniform or not, if they are asking for services, the health provider should be able to counsel, should be able to provide accurate, factual information, and therefore should enable them to have contraceptives or methods of their choice that they would like to have. Yeah. However, we live in a situation where besides the policy and besides the law, there are so many barriers that would make it very difficult for younger people to access the commodities that they want. One of them is the community context is not very supportive of adolescents seeking these kind of services. Yeah. The second one would be that health workers sometimes are not adequately prepared to respond and receive younger people when they come for these services. And either because of influence of culture or religion or other factors, then they become an obstacle towards adolescents receiving these services. The other factors are that the way our health system is structured, it may not be very friendly for adolescents to go there and get this kind of services. It could also be that the facilities are very far from adolescents, or the opening hours are not friendly to adolescents. And so a variety of factors then make it very difficult for younger people. But I think through education, through adequate preparation, through creation of friendly rooms and spaces that can be receptive to the youthful population and the younger ones, we can create a more friendly environment that enables adolescents to get services and information as when they need it.
Yeah, Lilian, let's talk about these contraceptives, and I'm sure there's several methods of these contraceptives, and they're those that clash with culture once again. So on the ground, when you're talking to people, how do you make sure that, when you talk about a certain kind of a contraceptive, it doesn't, get into it doesn't make the community be in a bad mood and, react violently, perhaps?
Well, I'd like to be pragmatic and maybe tell you about the reality on the ground. The issue is there's a lot of resistance to usage of contraceptives, and most of it maybe is built on the patriarchal way of life, whereby the decision maker mostly are males. Yeah. And for a very long time, they've been at the center of making decisions. Now, contraceptives are coming, and dominantly, and whatever we've had in the market, dominantly, are what is used by the woman. But as much as we want the woman to have the choice, most of the time, it's not the woman who has the choice, who makes this choice. We've had cases of women being refused from taking their pills, so they have to hide them at their neighbors, and that's where they go and, pick them. We've had cases of the church, the Catholic Church in specific, talking about the restricting its congregation.
They've been open about it.
Very open, and talking about don't use condoms, don't use all other kinds of contraceptives. And you see, this is an issue because when you go to the community, these debates, this conversation, they build on the culture on the ground, and so it affects access, first of all, because not only the community members, but even some of the medical professionals, you visit their clinics, and I'll speak to the adolescent. You visit the clinic, and you are forced to take very directive sort of counseling, and you're not given the opportunity to make the decision that this is the choice I want to make. It's actually imposed on you So such factors are affecting access.
Yeah.
They're even affecting the diffusion of information. And as much as we want to say that these services are available, the lack of information has been a very big impediment.
So there's a danger of some of the people in the population being misinformed, and this is where I want to bring Dr. into the conversation. What is the risk, perhaps, when, you know, some women getting misinformed about these contraceptives because of the cultural, you know, and these taboos? What are the risks if they end up, you know, using it in not a proper manner?
Well, of course, those contraceptives come with side effects. If I may mention, for example, a contraceptive like the injectables that we give every 3 months, it causes what we call anovulation. That's that you are not ovulating.
Yeah.
If you go for that method and you want to get a baby in the next few months, obviously it will be impossible because the return to fertility will be delayed as a result of using the injectable form of family planning, which is actually the commonest family planning method in this country. So you find if you don't get the proper information, you might end up waiting for years to get a pregnancy when you really need it.
Yeah, well put it, Albert. Now, Dr. Justice, sorry to call you Albert. Now, Albert, actually you're in my mind, and let's talk about these contraceptives. Once again, you said teenagers get a challenge in accessing them. So what do you think governments have the role to come and step in? Because if you look at these numbers, 396 deaths, this is a very big number.
I think our constitution is clear that everybody is entitled, you know, to good healthcare and good protection from government. I think the Kenya government has made quite important steps in terms of providing reproductive health services to younger ones from a policy point of view. So we have several policies that have been put in place which are supposed to enable adolescents to have access to services. So that's a bigger step that they have done. The second one is that the facilities across the country are being prepared to be able to respond to the needs of adolescents. We still have problems in terms of staffing. We have problems in terms of commodities, but some steps are being made to ensure that adolescents are having access to these services. What needs to be done is to ensure that healthcare providers are prepared to be able to respond to the needs of adolescents, but also to make sure that the commodities that adolescents would need are available each time they need them.
Well said, Albert. I think that will serve as your final comment. We're almost out of time. Now, Lillian, every government's promise, you know, every election year is that they're going to make sure that their population get universal healthcare. So leave that alone for now. And when do we expect Africa to realize a universal kind of access to reproductive health?
I think that's a long shot, if you ask me, because if you look at the legislation that is there, the international convention and all that, you find that, like in Kenya, for example, if you talk about the Maputo protocol, Kenya has ratified it, but then it has put reservation to certain issues. And one of the issues is on the issue of abortion, access to abortion. And actually, this is for Kenya and most of the African countries. So why the issue of providing the sexual reproductive rights in bits has really affected the provision of services. And I think we have a long way to go. But the good thing is that we have certain resources, online and offline. For example, earlier today, we had a round table with different stakeholders who were discussing the issues of safe abortion, built on the statistics that were recently released, showing that we're having 56 million abortions every year.
Those are illegal, I mean...
No, that is a mixture, but illegal fall into around, unsafe, fall into around 25. I'm not sure about the numbers. And the bulk of these are happening in Africa. And in the least developed countries. So we have organizations that are providing online resources. I mean, on top of my head, we have like How to Use that provide protocols on WHO on safe abortion, safe medical abortion. We have Safe to Choose that is working on providing online counseling and consultation so that it can reach those vulnerable youth, women who are not able to access the government services. So there's a lot of work that needs to be done. We need to build a lot of synergies with the civil society and everyone to reach that point.
I think you've delivered your point. Ms. Mukoko, finally, tell us what the DRC government is doing to reverse those numbers you've given us, 700 in every 100,000 women, right?
Okay. Well, the government is doing a lot, especially with adolescent and youth, because research showed that they are the bottleneck. You know, we've done already a good job with all the women. Now the bottleneck is adolescent and youth. So until like 2 years, young people in Congo needed the authorization of the parents to access abortion. So that was taken out of the policy. And now we are having youth-friendly spaces in hospital because, let's say for a city like Kinshasa, a 12 million people city, before we had only 4 youth centers where they were expecting all the youth to come for their sexual and reproductive needs. But now with the new approach of having spaces, youth-friendly spaces in every public hospital, we can reach more of them.
And give them more information, the right information, of course. Now, Dr. As to make your final comment very briefly, there's one viewer here, Dennis Malalo, who says very little is being done on reproductive health, and I think it's due to bad governance and corruption. As you make a final comment, do you think that also contributes?
Well, it's important that the country looks at the trend that we have had over the years, because generally, in terms of reducing the maternal mortality, we have not done very well over the years. Due to multiple factors, as we said. But having said that, it can't go unchallenged that some of us will not really support that issue of abortion as a service.
Yes.
So I don't think that would be the way to go. We would, as a country, look at other challenges, like, for example, what we are currently going through, the strike by the various health care providers. If those are to continue, then the next Kenya Demographic and Health Survey that we are going to have, definitely the maternal mortality ratio will go up.
We do hope that strike will be resolved very quickly. Many thanks, Dr. Justus Ngatia. You have something to say, Albert? Very briefly.
I think it's very important to emphasize that
very briefly,
the corruption is a way on the healthcare service delivery.
I think that's a point you've delivered already.
That must be addressed to provide the services.
Dr. Justus Ngatia, many thanks for your input. Francois Mukuku from DRC, thank you very much for joining us, as well as Lilian Mushoki and Albert Obai. Thank you all for your input. Of course, that is a discussion we've had here on Bottomline Africa. I believe now it's about time we cross to images of the day, where an Egyptian martial arts school is attempting to keep alive the ancient sport of tahtib by reintroducing it as a dance-like routine between stick-wielding competitors. Now, tahtib, evidence of which was first discovered on the walls of ancient Egyptian tombs, was until a few decades ago a violent sport which could lead to serious injury or even death. Now, the sport was first introduced as a means of training in sword fighting, but now represents a traditional dance of mutual respect and honor between opponents. It is often practiced during weddings in rural Egypt, as well as social gatherings and other celebrations. Looks like a very dangerous spot there from Egypt. Now, there's no way we can end the program without the African proverb of the day. Let's take a look at it. very interesting proverb there. But before I go to our bottom line tonight, let me just look at how Authoritative performed tonight. And we did ask you earlier, do you think enough attention is being given to reproductive health in Africa? 11% of you said yes, and 89% of you said no. Let me go through some 2 or 3 tweets very quickly because we're out of time. Isaiah Bero says, yes, attention is surely, it surely is getting a lot. I mean, he's trying to say that it's getting a lot of attention, but very little is being done to sensitize the youth and children about reproductive health. Hilary Chariot says, actually, the RH issue has been only focused to the urban centers, forgetting where the issue is a menace that is at rural areas. And then at Hari says, Matiangi, okay, forget about that. I think that is a political statement. And then at Maverick Kenya says, we are far behind. Sad, the basic family planning is still a subject of contention. Kisumu MCAs even dare argue family planning is bad politically. A very interesting comment there from Maverick Kenya. Finally, on the bottom line tonight, let us for a moment pause to reflect on one of the agenda of African First Organization. On the sidelines of the last Africa-France Summit in Bamako, Mali in June, the First Lady strengthened their resolve to ensure sexual and reproductive health rights for the continent's women. Now, why would reproductive health shake the core of the continent's executive to warrant such high-level discourse? Now, the United Nations Population Fund for Women says good sexual and reproductive health is a state of a complete physical, mental, and social well-being in all matters relating to the reproductive system. It implies that people are able to have a satisfying and safe-sex life. Now, the capability to reproduce and the freedom to decide if, when, and how often to do so. Now, while progress has been made in improving reproductive health, information and services in the continent, large disparities in accessing these services still exist within most African countries at a time when governments are yet to deal with even the most basic form of healthcare, let alone issues to do with reproductive health. Now, reproductive health is just but a woman's problem. Both men is not actually a woman's problem. Both men and women have equal stakes here. And here's my concern: in East Africa, statistics have stagnated or worsened in the past decade. Kenya, Uganda, and Tanzania all have maternal mortality rates or ratios that hover around at least 500 maternal deaths per 100,000 live births per year. Obstetric fistula, a chronic pregnancy-related injury which can cause incontinence and nerve damage, is particularly common in Africa. Now, in East Africa, an estimated 6,000 to 15,000 new cases of fistula occur each year. In 2007, FIDE Kenya published a fact-finding report on maternal health in Kenya. As a result of the report findings and the recognition that the Kenyan government was failing to fulfill its obligation on maternal health, the Kenya National Commission on Human Rights decided to commence a public inquiry on maternal health, whose scope expanded to address reproductive rights in general. Now, the long and short is that the right to reproductive health is a human right, and we all must pay attention. And that is the bottom line tonight. Many thanks for watching. And my name is Yusuf Ibrahim. Remember, this program is aired every Monday to Thursday. Until Monday next week, have a blessed night and good night. Bye-bye for now.